Okay, good evening, everybody, and happy Tuesday. Thanks for spending time with us as we dive into this important discussion around men's health. You might not know this, but tonight's event is extra special because June is Men's Health Month. And while men's health issues happen year-round, we like to take the opportunity in June to just place a more intentional focus on the education and treatment of men's issues. So thanks for spending the next 30, 45 minutes, hour with us to join this educational webinar and for prioritizing your own health. So a couple quick reminders before we get started. This presentation is totally anonymous. You're not on camera and nobody can see your name. So we do this intentionally because we want to have an interactive discussion. We want you to feel comfortable asking questions, even if you think they're embarrassing or you're not sure the right words to say. So to maintain your privacy, you can write your questions in the anonymous chat box at the lower portion of your screen. And Dr. Kapadia is going to save some time at the end of the presentation to answer as many as we can. We have a lot of people in attendance so far tonight. So remember, if you have a question, somebody else probably has the same one, so don't be too shy to ask. Our speaker tonight is Dr. Akash Kapadia. He's a urologist and a men's health expert at Georgia Urology. Dr. Kapadia has built his practice around helping men who are dealing with men's health issues, just like you. So he's got a wealth of relevant information to share with us tonight. Dr. Kapadia, thanks for taking your Tuesday evening to spend with us. You guys are probably tired of hearing from me, so I'll mute my mic and turn it over to you.
Excellent. Thank you, Amanda, so much for the introduction. Thanks to the organizers for this event tonight. I'm really excited to be here and talk to a lot of our Georgia Urology patients. As many of you know, Georgia Urology is the largest and most comprehensive urology practice in the southeast of the United States. And I'm just very proud of the fact that we're able to offer very specialized care to our patients. And really, that's the reason why we are here. And it's at the center of our focus. And so to that end, I'm most thankful to all of you who've taken this time tonight out of your busy schedules to talk about this very important topic. I know it's important to you. I know it's a difficult topic to discuss. And we, as Amanda mentioned, we highlight through June, which we've labeled and highlighted as a Men's Health Month. As she mentioned, these issues happen year-round, so this is just an opportunity to talk about it. I think that's where a lot of us men struggle. It's the conversations, and I'm really happy to be able to facilitate that. And hopefully, this gives me an opportunity in an expanded fashion to talk about these issues. A lot of the folks on tonight might be my patients, so you've heard me probably talk on these topics, but hopefully this gives you an opportunity to have a more expanded conversation. Once again, thank you to all of you for joining. The most important thing that I enjoy about these webinars is the ability to have interactions and answer your questions. So I think that's the most important part of tonight. So please do ask any question that you may have. And then, I think if you don't take anything away from this talk, what I want you to realize is that erectile dysfunction is a health issue. Okay? Just like anything else, it is a health issue. It affects our physical and mental health and well-being, and it should be addressed just like any other health issue. And you ought to realize that where there is a will, there is a way to fix it. So we'll highlight a few of those points during this talk. But we'll get started here. This is just a little bit about me, and I think many of you might have already looked this up or know this about me. This is my training background. If you wanted to learn a bit more about me, you can certainly go to my website, which is listed on this page. So let's talk about erectile dysfunction. And this next slide is perhaps my most favorite slide. This is the slide I spend a lot of time on. I think education is what allows patients to make very informed decisions. So I'm going to spend a little time on the next slide explaining what erectile dysfunction is. Erectile dysfunction is the inability to achieve or maintain an erection that's firm enough for intercourse. I think we all understand that. It's super common. About 1 in 5 American men that are 20 years or older experience ED in their lifetime. And this can vary depending on age, whether it's a temporary issue or a permanent issue. But more than half of men over the age of 40 have some degree of erectile dysfunction that's based in organic causes or true medical causes. It affects nearly 40 million American men. So this is not a minor issue. I tell most of my patients that, at some point in our lives, we're bound to get erectile dysfunction. We'll understand why that is. This is the anatomy of the penis. It almost looks like a face. You've got two eyes right next to each other, and you've got the channel underneath that looks like the mouth, and that's the urethra. The two spaces on adjacent to each other are called erectile bodies. And the way I explain erections are that erections are simply a battery-powered hydraulic system. That's how the penis is designed, and it's a unique part of men's bodies that this is the only organ that functions like a hydraulic system. The battery in this case is your brain and your spinal cord that sends signals or battery or nerves down to the penis, which then activates the hydraulic system. The hydraulic system itself is composed of two hydraulic chambers, what we call erectile bodies. These fill with blood as the signal comes in and the arteries dilate. A second thing that needs to happen in a hydraulic system is that the outflow has to close, and those are your veins. So in the penis, as the erection is building, the veins collapse and close, and that's how you maintain a high pressure erection. And now you can understand why the analogy of a hydraulic system tends to make a lot of sense. The other example I use is that of tire tubes. Essentially, what we have are tire tubes in the penis, two tire tubes that fill with blood. And that blood gets trapped within those tire tubes, and that's how we maintain a high pressure erection. Well, if you understand tire tubes, if you understand tires, you understand that there's wear and tear. When wear and tear happens, you have to get a replacement. And that's exactly what happens with erectile dysfunction. It's a wear and tear of your system, of your hydraulic system. And this will give us an opportunity to talk a little bit more about what the true etiologies are and how to fix them. So going back to the idea of your battery-powered hydraulic system, a few things that can go wrong that cause erectile dysfunction are the battery stops working. That's usually some kind of a condition affecting your brain or spinal cord. Things such as diabetes are very common causes. Men that have had pelvic surgeries like prostatectomies are potentially at risk of having the same battery issue. The second thing that can go wrong is the arteries don't work like they used to. That's similar to having cardiovascular disease or plaque disease, where the arteries develop plaque buildup within them that prevents them from dilating fully and pumping blood into the system. And then finally, the veins can leak. You can have a leak in the system, kind of like a hole in a tire tube. Those are some of the common causes of erectile dysfunction. And we'll talk about how treatments that we have will help address these as well. So now let's address the topic of causes of erectile dysfunction. As I hinted earlier, a majority of erectile dysfunction occurs due to a vascular issue. That's either the inflow of your hydraulic system not working well, or your outflow of the hydraulic system not working well, or a combination of both of those. So 40% of erectile dysfunction is because of vascular disease. Another approximately 45% is a combination of diabetes, which is 30% of men, and 15% due to medications. So these three causes really make up the majority of erectile dysfunction causes. There are smaller causes, as I mentioned earlier, like pelvic surgery or pelvic trauma that can result in erectile dysfunction, particularly men that have had a radical prostatectomy for prostate cancer are aware of this as a common cause in that population. Certain neurologic causes or endocrinologic causes can also result in erectile dysfunction, but the biggest takeaway is it's a vascular disease that's certainly more complex in patients that have diabetes. This is a really good slide about diabetes, and I take a lot away from this slide. Patients that have diabetes should look at this slide particularly closely. Patients with diabetes and erectile dysfunction are less responsive to oral medications, and I'm going to touch a little bit more on this when we actually talk about erectile dysfunction medications such as Viagra or Cialis. But the idea is that some of these medications do utilize the battery in order to activate your vascular system. When it comes to diabetes, it's almost a two-hit issue where not only are the nerves, the battery damaged, but the arteries also get glucose deposits, preventing medications from working well. In men with diabetes, ED is more severe and associated with a decreased quality of life, and we can understand that now that we know how these pills work. And in some patients, ED can be a presenting symptom for diabetes. We know, as a broad picture, that about 15 million men in the US have diabetes. So this is a common issue. And if you have diabetes, I know that there can be struggles with erections and the treatments. This is an important connector to heart disease and a little bit of a call to arms when it comes to your health. Symptoms of heart disease may develop within 2 to 3 years of erectile dysfunction. So ED can be a precursor to the diagnosis of heart disease. ED is an independent risk factor for future heart-related events. And the severity of ED is correlated with the extent of coronary artery disease. And finally, ED precedes coronary artery symptoms in almost 70% of the patients. I don't explain why that is, and this isn't a slide meant to scare you. I think, as I mentioned, it's a little bit of a call to arms to take good care of your health, and certainly maintain follow-ups with your primary care physician when it comes to screening for cardiovascular disease. But here's why ED is a precursor. On this slide, you can see the penile artery is about 1 to 2 millimeters in size. It is half the size of the coronary arteries. The coronary arteries are the arteries to the heart. So if you were to guess, if a man has buildup of plaque disease, which artery is supposed to go first? Well, it makes sense. The smaller artery is more likely to be affected first, followed by the bigger coronary artery. And that's why we believe that ED is an important predictor for cardiovascular or coronary artery disease in the future. Low testosterone can also be associated with erectile dysfunction. It's more common in men with obesity, diabetes, high blood pressure, cholesterol issues, prostate disease, as well as asthma or COPD. Part of our guidelines is to offer testing for testosterone when it comes to new diagnosis of erectile dysfunction. Testosterone particularly plays an important role in the desire or libido, the desire for sex in men. And it can play a smaller role in the actual driver of erections. And approximately 4 in 10 men over the age of 45 may have low testosterone, and that does increase with time. There are treatments available for testosterone, and if you have symptoms of low testosterone, I would encourage you to talk to your Georgia Urology provider about this topic and perhaps consider getting tested. This slide is specifically designed for my patients and men out there that have undergone prostate cancer treatments. ED is a big complication when it comes to radical prostatectomy, which is one of the gold standard therapies for prostate cancer treatment. And if you're dealing with this, if you've had this surgery, you understand that erectile dysfunction is a common complication after a prostatectomy. The reason for this is the battery, as we alluded to earlier. The nerves that give you erections are wrapped around the prostate like a shawl. And so while your surgeon may be very adept and very good at performing nerve-sparing robotic prostatectomies, there's still a period of time where erections are not normal. And that's the reason for that is partial damage to these nerves. And that's exactly why erectile dysfunction happens either temporarily or permanently after a radical prostatectomy. Another important topic on as we're discussing erectile dysfunction is the condition known as Peyronie's disease. Now, when I was in training, and perhaps maybe 20 years ago, this was a less common condition. We thought the incidence of Peyronie's disease was about 1% in men. As there's more knowledge, more information out there about this condition, we are finding out that this condition is much more common. Nearly 10% of men in their 5th or 6th decade of life develop this condition, and it is often associated with erectile dysfunction. This is a condition related to scarring of the penis in the tire tubes themselves that then results in deformities such as curvatures, as well as things like tissue deficits or hourglassing. And once again, I would encourage you to bring this up with your Georgia Urology specialist or your urologist to talk about treatment options for this condition. Well, now that we understand how erections work, we understand how things go wrong, let's talk about what the restoration opportunities are. Once again, I want to highlight the fact that if you've got the will, there is a way to restore intimacy in your life and improve your quality of life. Okay. So with that said, I'm going to highlight FDA-approved treatment options for erectile dysfunction. A little bit outside of the scope of this talk is non-FDA approved treatments for erectile dysfunction. So we'll focus mostly on the FDA approved treatment options. There are 5 FDA approved treatment options, and I'm going to highlight them based on, and I'm going to give you my personal opinion on each of them. The first and foremost treatment that most men like to try are medications, oral medications. These are what are called PDE5 inhibitors. There are 4 of them. Most commonly we try 2 that are generic. Those include Viagra and Cialis. The generic names are sildenafil or tadalafil. The other 2 are not generic yet, and therefore less commonly prescribed, and those are avanafil and vardenafil. Beyond the pills, there are 4 other treatment options approved by the FDA, and I'm going to give them to you in the order that I think is best. There are 2 treatments that I am not a big fan of, but are FDA approved, and I'm going to highlight those. And then we're going to finish by talking about 2 treatments that I think are phenomenal, and based on your history, your preference, and your liking, both of these treatments are potential options for restoring your intimacy. So the 2 that I'm not a big fan of, but reasonable options to consider: a vacuum erection device. This is well. Let me jump to the next slide really quickly here. Let's quickly talk about oral pills. How do they work? Well, what they're doing is they're dilating your penile arteries. So they work by increasing blood flow to the penis. They can be effective, especially early on in disease. When plaque buildup is not severe, these medications can work. However, they can be affected by things like food. There are side effects of these pills. Things like headache, facial flushing, upset stomach are commonly reported side effects from patients. Less at lower doses and more at higher doses, and that's certainly understandable. There are certain situations where it is not a good idea to take these medications, and there are contraindications, such as, for example, if you're taking nitrates for chest pain, it's not a good idea to take any of these medications. Important highlight here is that almost half of the men with ED who try oral pills give up on the pills, or they stop working. For example, if you've got a venous leak in the system, well, that's one of the more common reasons why pills stop working, because while the pills can dilate the arteries, they cannot do anything for the leak that's developed in the system. Importantly, men with diabetes are up to 2 times more likely to move on to other treatments. So those are oral pills. I encourage you to ask about them and try them if you haven't tried them with your urologist. Let's talk about what are the options beyond the pills. We're going to jump around a little bit here. I'm going to jump to the vacuum erection device here. This is a pump that creates a vacuum that pulls blood into the penis, and then that results in trapping of the blood. Now, the other important aspect of a vacuum erection device is a ring that's placed at the base of the penis. Because as you can imagine, if you generated this negative pressure with a vacuum and then took the vacuum off, well, the blood would just result in returning back to where it came from. So it does require a ring at the base of the penis. I'm not particularly a big fan of this therapy. I think a lot of patients don't find it enjoyable, frankly, for intimacy and sexual activity. It's cumbersome to have something like that on. So satisfaction can vary significantly. Side effects include difficulty in ejaculating, bruising or discomfort of the penis, pain, numbness, or having coldness to the erections. So once again, I'm not a big fan of this therapy, especially by itself. More common reason to stop it is the fact of discontinuation is the fact that it's not great at achieving or maintaining the erection. Important highlight here is that one of the studies show that a majority of patients after a radical prostatectomy decided to move on from things like vacuum erection devices. All right, second therapy that I'm not a big fan of. This is what's called a urethral suppository. Imagine you're using a Viagra or Cialis tablet and placing into the urinary channel that disperses into the erectile bodies, which then allows for dilation of your blood vessels. I'm not a big fan of this therapy. It's very rare for me to prescribe this. The reason is the success is not very high, especially if you've crossed the barrier of pills. It certainly can cause pain in the urethra. It can cause burning. It can cause bleeding in the urinary channel. And importantly, it is expensive. So it's fairly uncommon for me to prescribe this therapy. As you can see, these medications need to be kept refrigerated, and there's a pretty significantly high dropout rate in patients, for example, who've had a prostatectomy. So now let's talk about 2 therapies that I am a big fan of, and depending on what your goals are good options. One is injection therapy. And number two, the fifth and the most definitive permanent therapy is a penile implant procedure. And we'll talk about both of these. So let's jump back to that slide on intracavernosal injection therapy, or just plainly known as injection therapy. This is what you've heard of called trimix or bimix. This is done through a very small needle, similar to an insulin needle. In fact, it is an insulin needle that's placed directly into those erectile bodies that we looked at in the very initial slides. The injection then delivers this medication that dilates the penile arteries. So in effect, it's working very similarly to the oral pills, but the medication is a little bit more potent and delivered directly to the source, which is the penile artery, bypassing the nervous system and the battery. This can be effective. Despite good success, approximately 40% of patients do discontinue this therapy, often within 6 months. The reason is there can be pain associated with it. There is a risk of having a prolonged erection or priapism because of it. Over time, scar tissue can build up in the penis. In some cases, it can result in Peyronie's disease. In my view, some of the more common reasons are, one, there's a little bit of arbitrariness to this treatment. There is a fluctuation and variability in dosing that patients have to get adjusted to. And that can fluctuate from time to time to time. So there's that lack of reliability with that consistent dosing. The other reason is the cumbersome nature of it. It does need to be refrigerated. So anywhere you go, anywhere you travel, you have to carry a little cooler with you to keep the medication cold. Not to mention you have to go through security when you're traveling through air in order to take this medication through. So there are multiple reasons to stop this medication. I tell my patients, hey, listen, if you want to do this, this is a good 5 to 7 year program because I do think that over time the medications stop working or patients develop more and more scar tissue that then results in more difficulty with future treatments. And then finally, the fifth and the most definitive therapy for erectile dysfunction that is FDA approved and an important one to note is a penile implant procedure. How does it work? Squeezing the pump of that's placed within the scrotum away from the testicle transfers fluid into cylinders that are placed exactly in the same space that we discussed. These cylinders are customized to the size of the man's penis from tip to tip. So this is a very individualized and customized type of a procedure. What these cylinders do are simply take the space that's already there. You've got a cylinder space that fills with blood. In a case like this, we're placing cylinders that are customized to your size, filling that exact space that you have. That fluid comes from a container called a reservoir, in other words, a fluid tank that's placed close to the bladder in the pelvic area. And simply by activating the pump, you have the power of getting an erection at your fingertips. Okay. It's very important to realize this slide may not be very clear about how this looks, but this is a completely internal, completely discreet, and private device that nobody would ever know about if you didn't tell them. If you went to have a shower in a locker room, nobody would ever know that you have a penile implant. If you went through security through the airport, nobody would know that you have a penile implant. So I do want to highlight the fact that it's a very natural appearing and very discreet and private treatment for erectile dysfunction. It is highly effective. 98% of patients report satisfaction that are the erections that are excellent or satisfactory after a penile implant. We'll talk a little bit more about complications. We know from literature that at 7 years, 94% of penile implants are still working. So in general, you get about 10 to 15 year use of these devices, after which they can fail and certainly can be replaced if they do fail. So let's talk a little bit more about a penile implant. This particular implant is an AMS 700 device. It's the most implanted device and the only one with built-in antibiotic treatment that helps reduce risk of infection. This slide is actually a little bit older. Penile implants have been in clinical use for over 50 years now. So just last year, we celebrated the 50th year anniversary of penile implants. And certainly well more than 500,000 men have penile implants, probably close to 1 million at this point. So believe it or not, this is one of the oldest, if not the oldest treatment for erectile dysfunction, as it was developed in the 1970s. Things such as pills, as well as injections, actually came much later in the 80s and 90s. So implants really preceded most, if not all, the treatments that we have for erectile dysfunction. Certainly, these devices have gone through many iterations and are currently at their best stage in terms of durability and quality. We'll talk a little bit more about this. Let's watch a quick video on how an implant works. I might need a little help with this, but I think I got it. So I'll talk you guys through this as we're doing this. Here is a patient that likely has an implant, and you can imagine there's no external evidence of having an implant. You can see that there's a pump in the scrotum in its own little space away from the testicles that transfers fluid into those cylinders upon activation, and that fluid is transferred from that reservoir in the pelvic cavity next to the bladder. This man has a firm erection once completed with orgasm, ejaculation, and sexual activity. With the press of a button, the device is completely deflated and back to its normal state as the fluid is transferred from the cylinders into the reservoir. I want to highlight an important point that I did not make yet. It doesn't change in any way, shape, or form how you feel during intercourse. It doesn't change sensation, arousal. It doesn't change your ability to orgasm or climax. It does not change your ability to ejaculate. And it certainly doesn't affect your ability to urinate. This is a device that is completely natural in its flaccid state, as well as in its erect state. Now let's see if I can find a way to move on from these slides, from this slide. There we go. This is an outpatient procedure. It's usually performed in about 30 to 45 minutes as an outpatient procedure under general anesthesia. It does require a small incision. That incision can be either made between the penis and the scrotum, or actually above the penis near the pubic bone, which is called an infrapubic approach. Generally, it takes a few days to return to your regular routine activities. I tell my patients you're going to be a little bit sore and mad at me for about 5 to 7 days. In fact, that's changed quite a bit with the use of long-acting anesthetics, which really prevents the pain response in the first few days, such that most men are feeling quite comfortable immediately after surgery. The bruising and the swelling takes a few days to go away. I tell my patients time from surgery to sexual activity is about 4 weeks. So that's a relatively rapid recovery in order to restore your erections. It's important to mention that this procedure is well recognized by medical societies. It is covered by Medicare, which is a significant portion of our patients. And because Medicare recognizes this procedure as a viable and FDA-approved treatment for erectile dysfunction, most, if not all, commercial insurances also cover erectile dysfunction. However, we certainly expect to check with your insurance to ensure that it is a covered benefit when we do decide to choose this route. Certainly don't let this be a barrier to getting this treatment. Talk to your specialist, talk to your urologist at Georgia Urology, or myself if your urologist has not performed this procedure. And we can certainly talk about options that are still out there that may be out there for financial assistance and things of that nature. But once again, it is a well-recognized treatment and covered by insurance. With any surgery, there are risks associated with a penile implant. I would certainly, if you were to see me for this treatment option, I'd certainly highlight these in a much greater detail when we do meet to talk about this. One of them being a risk of infection that's usually 1% or less in healthy males. It is true that you cannot go back to your natural or spontaneous erections after a treatment such as a penile implant. Implants can certainly fail, just like any mechanical devices, and most patients would be a good candidate for replacement therapy. Certain things such as pain may be associated with having an implant, though this is an extremely uncommon thing after the healing process. Certain populations of patients may be at a higher risk for having an infection after a penile implant surgery. This is the part of this talk that is a little bit outside the scope of our conversation today, but I'll spend a couple of minutes on this. There is a lot of noise out there about erectile dysfunction treatments, especially if you search that on Google. You will not see a urologist in Google search. You will certainly see men's clinics that are out there. They are claiming to be experts. They're masquerading as experts, but simply profiteering clinics that certainly want to sell you treatments that are not mainstream treatments without having any particular expertise in these issues. For example, we know that stem cell therapy or platelet-rich plasma therapy with level 1 randomized trials have not shown to be beneficial in treating erectile dysfunction. And some of this data is still coming out and will likely be in the AUA guidelines claiming that they do not work. Shockwave therapy, true shockwave therapy, not gain wave or other forms of sound wave therapy, can be effective in men that have mild erectile to moderate erectile dysfunction, especially when they have arterial disease. Now, again, most clinics that are out there advertising this are not selling you true shockwave therapy. They're simply selling you a different form of therapy, such as sound wave therapy. And that's important for y'all to understand. The AUA considers the American Urological Association, which is the governing body of urologic practice and men's health and erectile dysfunction, considers this a very intentional therapy. So to summarize, ED is a common problem. Sooner or later, all men are going to experience this as our hydraulic systems fail. It's important to realize that there are a variety of treatment options. And as I mentioned earlier, if you take nothing away from this talk, please do understand that if you've got the will, there is a way to restore your intimacy. Certainly, penile implants could offer a long-lasting and satisfactory solution, including, importantly, spontaneity and reliability back to your intimacy. With that, I'll stop. I thank you guys for listening in. I think we've got a great audience out there. This is my information, and I'd like to pause and offer any advice I may have. Please feel free to ask as many questions as you guys feel comfortable. Let's see, it is 7 o'clock. We've got 30 minutes of time that we can certainly spend on discussing, answering your questions. So Amanda, I'll turn it back to you.
That sounds great. Thank you, Dr. Kapadia. So Dr. Kapadia has agreed to take a few questions. So just a reminder, put those in the chat. We've got lots of questions already in there already, but if you have yours, go ahead and drop it in there as well. And I'm going to ask Dr. Kapadia to just leave this information up on the screen so you can write down, take a photo with your phone, so that way you know how to get an appointment with him or your Georgia Urology provider after this webinar. So Dr. Kapadia, first
Amanda,
question.
can I pause you for 1 second? Because I think there is a QR code that we can put up on the screen. Is there any way we can do that? Is that on the last page, you think?
I think that Kelsey has that. I'll task Kelsey with that. She can work on that while we're answering questions. How's
Perfect.
that? Okay, so do medicines like Lexapro cause ED?
That is a good question. So Lexapro is a class of medications called SSRIs, selective serotonin reuptake inhibitors. For those of you that haven't heard about Lexapro or heard of Lexapro, this is an antidepressant medication that certainly has been linked with sexual dysfunction. Now, the data on this is variable. One of the main side effects of Lexapro can be delay in ejaculation. In fact, we use that medication commonly in men that have premature ejaculations. So that is a common side effect of pills or medications like Lexapro. It's certainly true that it can affect sex drive or libido in men, and that's also been shown in studies. And to a lesser extent, it certainly can affect erections as well, but less commonly than libido or desire for sex, as well as ejaculatory difficulties.
Thank you. Is there a correlation between BPH and ED? Maybe you could explain what BPH is first and then answer the question.
So yeah, I'll explain BPH in 1 second, but absolutely there is. That correlation is 1, being a man, and 2, getting older. BPH is benign prostatic hyperplasia. That's a term that pathologists use. Commonly, we in urology and patients recognize this as having an enlarged prostate. Enlarged prostate is typically a benign condition that's separate from prostate cancer. It's simply growth of your prostate gland that then results in difficulty with urination. Now, I don't have a picture of this, but imagine that you've got a donut hole that you're peeing through, and that's your prostate. As you get older, the tissue from the prostate continues to get bigger, such that the donut hole really turns into a keyhole that you're peeing through. And that makes urination very difficult. Folks that are at risk for BPH or enlarged prostate obviously are men, aging, and in many cases genetic. predisposition. Certainly, some families or some races or some family lineages have a higher risk of having enlarged prostate than others. So it can run in families, but more commonly, it's just a thing that men go through as we get older. In similar fashion, erectile dysfunction also happens around the same time in our 40s and 50s. As our prostates get bigger, certainly erections get weaker. Not necessarily due to a causal relationship, but something that happens temporarily or time-wise around the same time. The mechanisms of your hydraulic systems tend to develop problems alongside with the prostates getting bigger. I hope that answers the question.
Very good. Does an implant correct Peyronie's curvature?
Yeah, that's a really good question. I'm going to spend a little bit of time on it, but perhaps more time one-on-one with this gentleman that asked a very important question. Peyronie's is a condition of scar tissue, deformities of the penis that we briefly discussed. It can happen alongside with erectile dysfunction. So what's important to determine in that group of men that has Peyronie's is that is the quality of their erections. So, for example, men that have excellent erections have Peyronie's disease alone. We focus more on treatments for Peyronie's disease to help correct the deformity, such as curvature. In men that have erectile dysfunction, that's not responding to medications, and also have Peyronie's disease, well, that group of men needs a very specific treatment that addresses both issues. Typically, the most common guideline-based recommendation for that group of men is to consider a penile implant, because the implant allows us the opportunity to then correct any deformity or curvature that the man has because of the scar tissue on the external cylinders that give you erections. Because now implant cylinders are going in, so we can do anything we need to correct that curvature. So to answer your question, yes, absolutely. Penile implants can help correct Peyronie's disease and penile curvatures when the man has bothersome erectile dysfunction as well.
Great. Lots of questions in here about insurance coverage for the penile implant. Can you talk a little bit about cost and insurance coverage?
Yeah, and I think I've asked this question, or I've sort of talked a bit about this on the topic. Amanda, do you have a little bit of specific sort of questions related to this?
Yeah, I mean, it's actually the same question several times. Is penile implant surgery covered by insurance? What is the cost of the surgery?
Yeah.
So I think maybe just revisit.
Yeah, just sort of reiterating that. Yeah, absolutely. So yes, the answer is most commonly yes. It is a Medicare covered benefit. So Medicare patients do not know whether this is a covered benefit or not. 100% it is covered by Medicare. Now, there could be some variabilities to your plan specifically. Part 1, part 2, and I don't know a whole lot about that process itself, but the bottom line is it is a Medicare covered benefit, which means that you may have some out-of-pocket expenses, and that's really dependent on your individual plan in terms of how much deductible you have, out-of-pocket maximum you have, et cetera, et cetera. But the bottom line is the majority, the lion's share of the cost of an implant is covered by Medicare. Because Medicare covers a penile implant, most commercial insurances will also honor that. Now, again, your plans may vary based on what your employer has chosen to be covered benefits. But what I can say is that 100% of the time, our patients go through the process of insurance approval prior to going through surgery. So we would know before we sign up for surgery whether this is a covered benefit or not. In many cases where there has been a denial, we have services through different sources that offer the opportunity to appeal the denial to your insurance. So there are processes in place to help you out when there has been a denial from your insurance. So certainly I would not give up. I would be alongside with you to fight that if there is a denial from your insurance with an appeal process. And then finally, this is something that may not be completely hammered out in terms of out-of-pocket or self-pay implant surgeries with Georgia Urology just yet. That's something that we're working on polishing. But an implant can certainly be done if a patient wants to pay directly. And the cost of that would be something that we can discuss privately.
Very good. This is a fantastic question. Does the saline in an implant have to be refreshed or exchanged every so often?
Yeah. Good question. Now, patients ask me this all the time, but I think this may be the first time that somebody's sort of tuned into what's in there and asked that question, Amanda. So I think
so. Yeah.
Yeah. Great question. I tell my patients, you do not need to go to the gas station to refill. Okay, that does not need to be done. This is a completely closed system. The three pieces are completely closed, and they're built with durable material. And so, unless there's a break in the system, a leak that develops, you do not need to get these refreshed or refilled. It's also true that the saline that's in these systems is isotonic, which means it's very similar in composition to your body's fluid makeup. So what that means is when an implant does fail, say that you develop a break in the system after 15 years of using this device, well, you can imagine all the fluid can leak out. If that happens, your body simply reabsorbs it. So there's no damage or harm to you if you develop a break in the system. And similarly, you do not need to refresh the fluid, as it's a closed system that should not leak.
Okay, we got a couple good questions. So how long does a penile implant last? And if I decide I don't like it, can we remove it and use Viagra again?
Yeah, that's I highlighted this earlier, and that is a big no-no. Okay, an implant typically lasts 10 to 15 years. It can certainly give out well less than well before 10 years, but on average, our data would suggest a 10-year lifespan. As you saw on that slide, about 94% of implant devices are still working at the 7-year mark. So you can get certainly get well more than 15 years out of it, but certainly it can fail before 5 years or before 7 years. So my general sense on this is about 10 to 15 years is how long these devices are going to last. Now, this will continue to improve as we continue to improve these devices. Certainly, the time period was much shorter in the older versions of these devices from the 70s and 80s and 90s. Now those devices are actually lasting quite a bit. Right, so that's number one. Number two, as I mentioned earlier, you cannot go back to your natural erection. What we've done is we've taken over this space that you have, this potential space that fills with blood, and placed the cylinder, these silicone-based cylinders within that space. So if you do not like it, you certainly cannot go back to removing that device and using Viagra. My sense on this is men are choosing this treatment option because either Viagra or Cialis or the pills have failed, number one, or they're just not happy with that treatment. So it often is a moot point to discuss returning back to pills, because as we know, most patients that choose this therapy may not have had success or have failed to have success over time with these pills. And then along that, I just want to highlight one more thing, Amanda. Once you have an implant, you also cannot stick a needle into those cylinders. Okay, so you cannot do injection therapy if you have an implant, because imagine this: now you've got a true tire tube within the penis, and with a needle poke, you're making a hole in that tire tube, and that will result in the fluid leaking out.
Very good. I have been to a men's health clinic in the past, and they never mentioned penile implants. Why is that?
Yeah. Well, I touched on this a little bit in one of the slides that talks about non-traditional or non-FDA approved therapies. These men's clinics that claim to be expert, they're masquerading as experts, right? They are simply folks that have some degree in something that are offering injection therapies and certain other things simply because they can legally. But they are no true experts in erectile dysfunction treatment. They're certainly not surgeons that can offer you the full comprehensive menu of treatments, all the way from pills to the other four, to the 3 non-surgical treatments we talked about, all the way up to the surgical treatment, which is penile implant. So yeah, I mean, these are not urologists typically. There are men's clinics that are run by either a nurse practitioner or a physician's assistant, who are simply supervised by a healthcare provider of unknown specialty.
Does being diabetic impact the effectiveness of a penile implant?
The short answer is no, it does not. Because remember, we are bypassing our natural hydraulic system and mechanisms to place essentially what's a bionic cylinders or bionic implant. So the short answer is no, it should not limit the ability or limit the functionality of an implant. Now, having said that, patients that have diabetes, especially chronic long-term diabetes, those men certainly have more scar tissue within the penile cylinders, which can make surgery a little bit more difficult. those men also have atrophy of that tissue and shortening of the penis. And it's important to highlight that while implants can capture every centimeter of length you have left in the penis, it certainly cannot take you back to who you were 20, 30, or 40 years ago when you did not have diabetes or did not have other health conditions that's resulted in shortening of the penis. So that aspect's really important to understand. We also know that men that undergo this procedure with uncontrolled diabetes are also at a higher risk of developing an infection post-surgery. So if I'm seeing you and you have uncontrolled diabetes, I'm really working hard on getting that diabetes under control. It's your call to action to take control of that diabetes and beat the diabetes in order to get an implant. So that's often a motivation for a lot of my patients to really control of their diabetes care. But yeah, it should not affect the ability for the implant to work, but certainly there can be nuances and challenges to the implant surgery and the success with diabetes.
Is there an age limitation for implant surgery?
Yeah, I love this question every time. The short answer is absolutely not. On both ends, really on both ends, right? So this question is probably coming from someone that may be concerned about the high end of age being an issue. And I'll tell you right now, it doesn't matter what the number is. It's really how you feel, and in some ways, what your health conditions are. If you're a healthy 85-year-old, there should be no reason why you can't get an implant. In fact, my oldest patient is about 88 years old. So once again, there's no top age limit to get an implant. Certainly your health conditions do play a factor in that decision, but that's something we can discuss on a more individualized basis, right? On the other end of the spectrum is younger men. I think that there are certain situations and rare cases where men in their 20s or 30s may need an implant because of true vascular or organic diseases. However, the wide majority of men that are in the younger age group don't typically have organic or vascular diseases that necessitates an implant. And so that's an important conversation to have with your urologist. I've certainly done implants in patients that are younger, but generally it's a solution for men, really starting from their 40s or late 40s all the way up to their 80s.
Okay, I'm new to the dating scene after losing my wife 8 years ago.
Mm-hmm.
Needless to say, no erection. Could this be mental or physical, and how will I know the difference?
Yeah, I'm gonna make a guess that this is an older gentleman who's unfortunately lost their partner. This is a very, very common scenario in my clinic. So I'm talking directly to you. I think loss of a partner is very impactful in many ways and affecting our quality of life. And then more importantly, seeking that intimacy, both mentally, physically, with another partner, can be very difficult when you lack confidence in being able to be intimate and being able to provide satisfaction to a new partner. So that is often very difficult when men are in that scenario, seeking out new relationships at an older age. This is a very common patient population of mine, and I know for a fact that this is the group of men that have a dramatic rise in confidence and mental well-being after an implant surgery, because it does give you that confidence, that reliability, that spontaneity of having an erection. It's hard to have a conversation with a new partner about not being able to get erections and perhaps needing tools like injections to make things happen. And so I think an implant is one of the most spontaneous and confidence providing solutions for this group of men.
So after having radical prostatectomy, how long does it take to heal and regain your and have your sex life back after healing?
Yeah. To follow up from the same topic as we discussed on the last question, this is the other group of men that find an implant a life-changing solution. The reason for that is this is often a group of men, in their 50s or 60s, that often walk into a prostate cancer scenario with relatively good erections and good intimacy and good sexual life, and suddenly lose the ability to be intimate with their partners as soon as a radical prostatectomy has been done, along with having issues such as urinary incontinence. And this group of men, the sudden loss of erections it has a tremendous impact on their health and well-being. And this is the other group of men that benefits significantly from an implant because of that confidence, the reliability and spontaneity that they used to have just prior to their surgery. So this is the other group of men that has a tremendous benefit from having implant surgery. Having said that, we know that there is a process of penile rehabilitation that takes place after a surgery. We know that erections can return up to 12 or 18 months after your prostatectomy. Having said that, there are some men that walk into a prostatectomy with having poor erections. Okay, those men do not need to wait the 12 or 18 months to restore erections. If it wasn't there before, it ain't going to be any better after surgery, right? So those men need to be a little bit more aggressive about treating their erectile dysfunction. Alongside that, if you are hoping to have your erections restored over time because of a nurse-bearing prostatectomy, we don't just wait and watch. I think that's not conducive to a healthy, normal life with your partner. I do encourage that if you are planning to wait for 12 to 18 months prior to choosing a surgery or surgical therapy such as an implant, let's do something else about it. If pills are not working, let's talk about injections as a temporary therapy until we know that your erections are restored over time, or that they're not going to be restored after 12 to 18 months. So in summary, it can take 12 to 18 months to restore erections, but that doesn't mean we keep waiting the whole time. There are things that we can do to return intimacy back to your life. And that's usually at the 3 to 4 month mark that most men are ready to resume an intimate life with their partners. And then finally, as I mentioned, if you didn't have erections before, don't expect them to come back 12 to 18 months later. Let's be a little bit more aggressive on urotherapy.
We've got a couple good ones in here. So can I have the surgery without my family and my colleagues knowing? Can I tell them it's something else?
Yeah, I get this commonly. It often is a issue of stigma. It's often an issue of privacy. It's often an issue of feeling uncomfortable sharing with family. And it's often a cultural issue where this isn't something common in certain cultures. So my answer to that is your choice. That is your prerogative. You can choose to share whatever you want to disclose to your family members, to your colleagues and friends. Certainly, you're not required to share any of this with your colleagues and friends, and you're also not required to share this with your family members. I'll often guide patients on what they can say. And often they'll say something along the lines of, I'm having a urologic surgery for my bladder or prostate, or I'm having a hernia repair, or something of that nature. So feel free to use those as guides, but this is your call and your choice to share this decision with whomever you want to.
I think we've got time for just a couple more. So can fatty liver disease lead to ED?
Say that one more time. Liver disease?
Yep, fatty liver disease lead to
Fatty
ED.
liver disease. Okay, that's a very specific question. Liver disease itself can result in a variety of what we call metabolic syndromes. So that itself can result in erectile dysfunction. Patients that have liver disease are also very high risk for developing testosterone deficiency. Testosterone deficiency can in turn result in erectile dysfunction as well. So by way of multiple different mechanisms, it is possible that liver disease can be a sign of having metabolic disease and can result in erectile dysfunction. But fatty liver disease specifically is a very unique diagnosis or condition. Fatty liver disease may not be associated with true liver disease. It's simply and often a finding on imaging studies, such as ultrasound or a CAT scan, where the radiologist has said, you potentially have some fatty liver disease. I can't claim that exact condition seen on imaging results in erectile dysfunction, but liver disease as a whole certainly can.
How can you tell if you have a venous leak condition causing ED?
Yeah, that's a really good question. And the answer to that is there are ways to find out from an imaging standpoint. Whether that changes the treatments we choose may not be the case. So for example, most men certainly do want to try oral pills without necessarily knowing the exact etiology of their ED, because regardless of what the cause of ED is, whether it's an arterial issue or a venous issue, the treatments are still the same 5 ED treatment options. But having identified a venous leak does help us move forward with our decision making. For example, men that have failed oral pills will have later be found to have venous lead, occlusive disease. Well, we understand why that is, and we then understand why those men are more likely to fail with other forms of therapy, such as injections, for example, and they may be a better candidates to move more efficiently, quickly to a penile implant surgery. So in that situation, identifying the exact cause is important. The way we identify the exact etiology of your erectile dysfunction is doing a special imaging test called a penile Doppler ultrasound study. This is a study where an artificial erection is given through a trimix injection, and then the vasculature of the penis is then studied with an ultrasound machine in a very dynamic fashion. So this isn't something that a radiologist typically does. This is something that's done in a urologist's office. And in fact, I do a wide majority of penile Doppler ultrasounds myself in my office for a good number of our doctors around my practice. So that's something that can help us identify the exact nature of erectile dysfunction, including venous leak.
All right, I think we've got time for two more. So I don't have a problem getting erections, but I'm having trouble finishing. Is there anything that can be done to treat this?
Yeah, so that's this question is particularly related, for men that are listening out there. This is related to the question of having orgasmic or ejaculatory issues. And often I do have men join these webinars to ask about these questions, and I think it's important to help address this. So this gentleman, or perhaps just a question from someone, is asking, unrelated to erectile dysfunction. They're able to get erections, but they're not able to finish or orgasm and potentially have ejaculation. There can be a variety of medical causes that result in this problem. Somebody asked the question about Lexapro. Now, SSRIs or medications like Lexapro can cause difficulty in ejaculating in men. So that's something that I would evaluate more specifically in an individualized way for this patient. What are their exact risk factors for having that issue? And how can we fix this? So medications can certainly cause ejaculatory difficulties in men. For example, men that have had a prostate procedure for enlarged prostate can have ejaculatory problems. Now, they may still be able to orgasm, but may not be able to produce ejaculation. That's a very specific problem based on the patient's history. And then finally, there are men that have testosterone deficiency that can also present with ejaculatory difficulties or orgasmic difficulties. So it's important to do some blood work and look into your hormonal blood work to understand what your risks may be. But in many cases, these conditions are quite difficult to treat if I can't identify a cause for it. There are a few things we try to help with the orgasmic ejaculatory portion of intimacy, but they can be difficult to treat and are certainly separate from the mechanisms of erections.